Yeah, good evening, everyone. Dr. Kaladar here from Yashoda Hospitals. Welcome to our Tuesday webinar from the Department of Critical Care Medicine, Yashoda Hospitals. We bring forth these sessions regularly and where we have alternate masterclass and presenting trending issues and interesting topics in alternate Tuesday. So every Tuesday we bring forth these classes from the Department of Critical Care. So today we have a case discussion wherein we will be delving into toxidromes and OP compound ingestion. As we know, toxicology is a very integral part of critical care. We do deal with these cases day in, day out, and most of the times they may pose challenge because sometimes unknown poisoning will be there. So the toxidrome approach, something like cholinergic, anticholinergic, opioid, sympathomimetic. This is all the toxidrome approach where we will be arriving at a diagnosis sometimes. Sometimes it will be known something like OP compound, where phosphorus compound ingestion is a very common thing in India, being a agricultural backed country. So we do see these cases very regularly, right from a bit moderate cases to very severe cases. So we should be knowing, like as a critical care, thoroughly about in and out of how to manage and how to approach these cases. So to deal with this, we have two senior seasoned examiners. We are lucky to have them on board. Dr. Ashit Egde sir is the head of the department of Hinduja Hospitals, critical care medicine. So sir is this is I think third time. He is having a vast experience. It is very he simplifies the approach such a way it is very easy to understand, and it will consolidate in our mind, and we'll get a great knowledge. Thank you, sir. Welcome you on board.
Thank you.
And Dr. Tanmay Ghatak is the Associate Professor of Emergency Medicine from Sanjay Gandhi Institute of Medical Sciences, Lucknow. Such a premier institute dealing with these cases day in, day out, have a vast experience. So definitely will add in a lot of insights from his side, which will be helpful to the students. So we have Dr. Kola Venkataraman, sir, none of the mastermind behind all these things who pushes us to conduct these sessions. These sessions are available in YouTube as Yashoda Masterclass. We do upload these regularly. Most of the students, clinicians, even from the second tier cities, they regularly call up to us and tell that these sessions are very helpful. Some people call up to me and ask to send the links very regularly, something like from Nalgonda, Nagar, and all. So we do see this, and even across India, see other students also. They call up. Recently, some student called up from Mumbai and told that, sir, one class is not uploaded. Please upload. It will be helpful. As such a reception across the nation. Thank you very much for that. So we have two students today with us from Yashoda Sikindrabad, Dr. Vaishnavi and Dr. Vinay. Both are second year DRNB students. So they will be presenting the live case which is there presently in their ICU. So we will go through this case as we go through. Dr. Ashit sir and Dr. Tanmay sir will be asking the questions. Vinay and Vaishnavi, please start the case. Yeah, thank you.
Thank you, Venkat and Dr. Kaladhar, for this invite.
Thank you, sir. It is all yours, sir. Both of you can take over.
Good evening, sir.
Then go ahead.
Yes, sir.
It is visible.
A 44-year male resident of Yadagiri Gutta presented to emergency medicine department with multiple episodes of vomitings, 7 to 8 episodes on 26th May with the pungent smell in order. Upon inquiry with family members, given a history of consumption of monocrotophos at 1:30 p.m. on 26th May, around he had consumed around 250 to 300 ml. Initially went to outside hospital within 30 minutes and underwent a gastric lavage and shifted to Yashoda Hospital for further management.
So fine, Kaplan, go back. So first, of course, this patient has given a history of poisoning, but generally what will otherwise, if there is no history, what will make you suspect poisoning?
He had a...
No, in any patient, not in this patient. This patient is pretty clear. He has a lot of things. I'm just saying any usual patient coming to emergency, what are the things, when you do suspect poisoning?
We take
But
a
there's no
ABG.
history. So which are situations where you suspect poisoning?
If at all his hemodynamics are unstable,
Any unstable patient, do you think of poisoning first? No, no.
No, sir. Sudden onset of any altered behavior.
Yeah, so which, especially younger patients, no? I mean, so especially younger patients who come with elderly patients, lots of reasons. Younger patients coming with altered sensorium, unconsciousness. So generally younger patients, isn't it? So what? Hypotension is not first thing you won't think of poisoning in hypotension. No? Hypotension will think about infarction, embolism, sepsis, everything else. You don't think of poisoning number one. So what are the occurrences? What are the features that make you think consider poisoning in patients who come to the emergency or ER or ICU? The one I told is altered sensorium or abnormal behavior in a younger person. What else can make you suspect poisoning? Unexplained acidosis, maybe. Unexplained blood gases,
Acidosis,
bizarre rhythms. I'm just saying these are things that will make you suspect. Obviously, smelling from the mouth is an easy thing. Patients with a history of attempted suicide in the past. Patients with psychiatric problems. I mean, these are things you should be able to rattle off in the exam. Huh? Don't think so much for one question. So when did you suspect? And then, of course, on examination, there are enough toxidromes. We'll talk about toxidromes. But so these are one question that you might be asked. Huh? Okay.
okay.
And when you suspect poisoning, what are the things to tell the family again to search in the house, no, for or any tablets or any medicines or whatever. Okay.
That's why toxidrome came into account. What is toxidrome? What is toxidrome means?
It is an amalgam of signs and symptoms which has been describing regarding the condition which poisoning has been fitting into.
That means you're suspecting some toxicity in some patient depending on some syndromes, no?
Yes,
Some
sir.
symptoms.
Signs and symptoms.
Okay. No? Maybe a cholinergic, maybe anticholinergic, maybe sympathomimetic, like this. No? So what sir has said, where the behavior is abnormal or something that you cannot explain. Maybe patient is having meningitis for ultrasound, but it is not fully explained by meningitis and encephalitis like that. Then you can think about this toxicity or sudden onset of things. He was all right few minutes before. Now he is having some symptom, of sudden onset vomiting with a pungent smell, like in this case. What may be the DDs in this patient? In this patient, he is giving a clear-cut history of intake. If it is not there, what will be the DDs?
Acute gastroenteritis can be occurred, sir. Because of
Anything more?
vomitings.
Because of vomitings.
And pungent vomitings.
Which other
Any
conditions
other
I think is some funny smell?
Any other toxicity or any other condition like this, vomiting with special odor from mouth, very common.
Alcohol, sir.
Okay, maybe something more.
And on cyanide poisoning also, bitter almond taste is there, sir.
Abdominal pain along with that. Patient is having abdominal pain, few vomiting episodes. In the background of diabetes,
DK, sir.
Diabetic ketoacidosis.
any other person can present like this, toxicity of any person. Heart patient having this. How will digoxin present? How will digoxin toxicity still present like this, with bradycardia? So what is the monoprotophos you are writing? What is that?
It is a dimethyl compound, sir. It is a
Of
dimethyl
what compound?
organophosphorus compound.
So what is the significance? Why you said dimethyl? What are the other kinds of organophosphorus?
We will have dimethyl group and diethyl group, sir. And newly
We'll talk about that as we go. So, what are the different classifications of the different classifications? One is dimethyl and diethyl. What are the other classifications of organophosphorus compounds?
Have you heard the WHO classification or something? in organophosphorus compound classification.
Grade
It is
1.
very important, I think.
Okay, sir.
1, 2, 3.
1, 2, 3, 4, 5.
One. You know that?
1, 2, 3 are the main. 1 is dangerous or 3?
One is dangerous.
1 is dangerous. And this monochrotophos is under which category?
One, sir.
Grade 1.
Grade 1.
So ideally should be banned, but not yet banned in our country. But ideally it's banned from most countries. So one is the WHO classification, 2 is dimethyl and diethyl. What are the other classifications of organophosphate?
S-alkali group also being present, sir, where
One?
prophenophos is coming under S-alkali. Alkyl group.
No. What is the classification? One is WHO, one is methyl and ethyl. What are other classifications? Other of organophosphorus? Because they all have implications in management, no?
What she is saying, sir, I've read in pharmacology, maybe forensic. That is not important in management. Maybe some important is there. Alkaline and aryl, what you're saying. What Sir is asking about solubility, about oxime and another thing, phosphate group, phosphate binding. That's Sir is.
What fat soluble versus
Yes.
water soluble?
Why it is important? Why
You haven't
we are
heard of
interested
oxones
in
and
fat
thiones?
soluble, no? You water soluble. Why we are interested in oxime or thiones?
Because fat soluble compounds they are slowly they are distributed in the tissues and they slowly release it, sir. In them after 24 to 48 hours only we can see the clinical manifestations, sir.
No, not after 24 hours, but the symptoms can persist for a while because they're stored in the.
They can have persisted.
The initial symptom may not be that severe, but the symptom may be persistent. Not that you treat after 24, 48 hours, but the symptoms may be persistent. And what about oxones and thiones, you know?
Sir.
And another important thing, water soluble will be easily excreted.
Easily excreted.
What are your views on gastric lavage in poison?
If a patient ingested in large amount and if he presented to the ER within 1 hour of ingestion, there is a small edge. There is a small better extraction of the toxins from the stomach, sir.
What precautions? When is gastric lavage contraindicated?
Contraindicated in ongoing seizures, vomitings, multiple episodes.
What kind of poisonings? No, vomiting you can do it. You can protect the airway and do it.
Yes.
Anyway, the vomiting already doing gastric lavage, so that's okay. But
what is the threat? What Sir is asking, and what types of other poison? Not here, other poison also. It is contraindicated.
Acid.
Hydrocarbon ingestion, sir, or corrosive ingestion.
Like common hydrocarbon ingestion.
Any rapid absorption in some poison causes rapid absorption from the GI tract. In that also there is no indication, sir.
No, which is contraindicated. I didn't say no indication is different from contraindication.
No indication, yes. No indication.
When is it contraindicated?
Contraindication. You will give and you will.
Is it corrosive poisoning? You're right.
Yes,
corrosive poisoning is contraindicated.
Hydrocarbons is contraindicated.
Now, why is
Kerosene poisoning, hydrocarbon. Why?
In corrosives, there is a risk of GI perforation is there, sir.
Fine, and hydrocarbon?
Hydrocarbon, why?
Risk of aspiration is high, sir, in hydrocarbons.
Fine. And any other poisons, rarely strychnine poisoning and all that also, but that's rare. And then, of course, so what are the precautions you take before doing gastric lavage if you are doing a gastric lavage?
Yes. What is the threat?
Aspiration risk may be present.
So the patient has to be
Intubated.
No, not everybody. Conscious or cooperative.
Conscious and
Conscious, you don't have to.
You have to take care of airway first, then.
So he has to be either conscious and cooperative, or if he's not conscious and cooperative, then you might think about protecting the airway before you do your gastric lavage. So in this patient, which patient do you think you can do gastric lavage beyond 1 hour? It might be okay to do it beyond
any
1 hour.
extended release tablets, any extended release drugs, or any prolonged gastric emptying drugs is there? No?
Which drugs exactly? Prolonged gastric emptying, which drugs cause prolonged gastric emptying?
Like
Beta blockers.
Beta blockers, gastric emptying. Common
carbamazepine,
poisons cause prolonged
carbamazepine,
gastric emptying.
and
Which common poisons cause prolonged gastric emptying?
You are using it day in and day out.
For sedation, which sedative you use? Cause prolonged gastric emptying.
Which analgesic you are using? Yes,
Anticholinergic.
opioid. Someone is writing in the chat box. Morphine. Yes.
Narcotics, no? And which other drug? Anticholinergics, no?
So outside hospital have done something about decontamination. What are the other decontamination you are thinking?
So there are
to do?
interactions in the online, sir, just for making
Yeah.
them so involved. We can also discuss and put questions, so Kaladhar can push those questions. So
So they are quite
keep
active
a
and they are
watch, we can keep
answering
a
as well.
You're
They are
answering.
answering as well.
Yes. That's good.
Okay.
So what are
the
the decontamination? What are the different decontamination we will do?
decongestion, sir. With
Decontamination.
with activated charcoal or polyethylene glycol, sir.
No, before
that. What is the role?
Start with simple things first, then go to activated charcoal. No? First, simple decontamination is what? In anticholinergic. You don't say you go to activated charcoal. You always start with simple steps, then go to your more complicated things. No?
You can give it the
So somebody this man has
normal saline, sir.
one
normal saline.
No, even before
normal saline lavage, so it has been given. First thing has been done, I think, within 30 minutes. What are the other? In this
is fat soluble, you said, no? Monocrotophos is fat soluble, you said, no?
Water soluble.
Water soluble or fat soluble? What did you say? No, what precaution you take in some organophosphorus? One is gastric lavage, but and other things you do for decontamination is what?
The other decontamination, what you are doing?
We will remove the contaminated clothes.
Remove all the clothes. That's important. What else?
And
wash with soap
and
with
water.
contaminated area over this complete body, sir. Complete body we will wash with soap and water.
And even the eyes, eyes also have to be.
Conjunctiva. What about conjunctiva? Is also to be done. Eh?
And what precautions take when decontaminating?
Very important.
Sorry, sir.
Protective equipment, कुछ तो पहनोगे, so it will, you have to wear, na?
Because though it's not been very rare, but you can, the person doing the decontamination can either inhale or absorb the.
Yes, sir.
So he has to wear gloves and mask and all that, huh?
Yes.
Protective. You don't just take off the clothes.
Which gloves to be used in this case?
Nitrile.
It is not available. What will you do? Is it available in the setup? Go for double gloves, triple gloves.
Yes, sir.
Okay. And what about charcoal? You said no?
Yes,
2 minutes back.
If any toxic compound can be absorbed by the activated charcoal, in that kind of poisons only we have to use it, activated charcoal, sir.
But what is the evidence for activated charcoal in organophosphorus?
There is no evidence to support it will be helpful in OP poisoning, sir.
Yeah. So though it absorbs but probably the drug is because these are cholinergic drugs are prokinetic agents, no? So probably the drug is already absorbed before you give the activated charcoal. Therefore, there's no evidence, though people try in desperate situations, but there's no evidence to say that it makes a difference in activated charcoal, and also there's a risk of aspiration. So if you're giving activated charcoal, you have to make sure your airway is protected, but no evidence, hard evidence in its benefit. But can they move it, Dr. Katak, or next slide? no?
Yes, sir. Yes, sir.
Yes.
Primary survey, airway drooling of saliva was present. Breathing, rapid shallow breathing with saturations of 92% on 8 liters O2 per minute. Circulation heart rate was 60 per minute. Blood pressure was 100 over 60 mmHg. All peripheral pulses felt. Disability, drowsy, responding to pain. With the pupils bilateral pinpoint. Exposure undergarments soiled with fecus and urine. Sweating was present. Pesticide smell was noted. GRBS noted was around 170 milligram per deciliter.
What are other causes of pinpoint pupils and drowsiness?
In case of OP poisoning, we can have
That is already said. What other causes there, sir?
Any hemorrhage?
In opioids, sir.
Pontine hemorrhage we can have
A pontine hemorrhage. And what other cause of pinpoint pupils and drowsiness?
Opioids, sir.
opioids, sir.
Opioid, yes. So opioid.
Opioid, I've already said.
Pontine stroke, it could be pontine stroke or pontine hemorrhage, both. But yeah, so pontine and opioid poisoning would come also earlier. Huh? Can you get
Alcohol?
tachycardia and hypotension in organophosphorus poisoning?
Yes, sir.
How?
Do you always get bradycardia and hypotension?
If it is a nicotinic receptor stimulation, in such conditions we can get hypertension, sir.
You can get tachycardia, okay, fine.
Tachycardia,
Right.
hypertension. Whereas in case of if it is muscarinic receptor stimulant stimulation,
Depending on what is stimulated and how much, so you can get either.
Sir.
Fine. Any other questions?
Depending upon which receptor is stimulating, sir is saying. Why there is respiratory problem in this poisoning?
Sorry, sir. Not audible, sir.
Why there is respiratory problem in this poisoning?
Respiratory.
Why is having shallow breathing with SpO2 low?
Because of the because of this muscarinic receptor stimulation in respiratory system, there is a CNS depressant, sir. Along with that drooling, because of the secretions that have been pulled up, they will have a bronchospasm leading to the decreased respiration.
Because of parasympathetic
overact, and also because of the sustained prolongation of the.
What is the mechanism of action of this poison? Just asking for basic.
Yeah.
What is the mechanism? What is the mechanism of action?
With the
Why?
acetylcholinesterase enzyme by deactivating through phosphorylation, sir.
What does it do? It's a
Acetylcholinesterase inhibitors are such that the acetylcholine levels have been increased at the neuromuscular junctions, CNS, and also in the peripheral nervous system, sir. Because of this acetylcholine that has been available, it has been stimulating the parasympathetic nervous system, sir. Overstimulation.
Result in continuous stimulation followed by paralysis, sir.
fine. Like a cholinergic crisis. Fine.
Cholinergic crisis.
Fine, go ahead.
So there is.
Sorry, you want to ask something?
So there is bradycardia with hypotension. What will be the other DTs? Bradycardia with hypotension.
Opioids, sir.
Is it common with hypotension? Bradycardia is common with hypotension, or a bit irregular? It is not common, na? So what are the causes of hypotension with bradycardia?
Hypotension with bradycardia.
Beta blocker,
calcium channel blockers, opioid toxicity.
What is spinal shock?
Spinal shock is a condition. It is a misnomer, sir. Usually there won't be any hemodynamic instability. In that, in such case, it involves if at all any part of the spine has been affected, the spinal shock can occur, sir. Where the initially reflexes has been loss of.
Any part of the spine? Any part of the spine? Or?
Usually cervical and.
No, where is cervical?
No, sir. Cervical, it's most common. Neurogenic shock will be most common in cervical.
Why is spinal shock and neurogenic shock? I'm asking the same.
In case of spinal shock, it is loss of vasomotor tone and reflexes have been lost, sir.
Due to what? Due to what being affected? So where the level? Where is the sympathetic outflow end?
In neurogenic shock, sympathetic flow has been affected, sir.
So where does it
Especially
end? What is sympathetic outflow end? Where? What level?
cervical and higher thoracic, sir, about T6 level in case of
Below
neurogenic.
that you won't get, no? Then you get parasympathetic, no?
Yes, sir.
So you said anywhere in the spinal cord, not anywhere. It is. Okay.
In neurogenic shock, we will have bradycardia and hypotension.
Fine. Elderly patients, other things you can think about in elderly are sick sinus syndrome, hypothyroid. Those are,
Yes.
but I think these are some of the other things that you can. Bradycardia, hypotension, no? Like somebody's mentioned inferior wall MI.
Yes, sir.
Yes.
Exactly.
So what toxidrome you are getting? What is that mnemonic called?
Sludge.
Here in this
Sludge.
survey, what you sludge
Saliva.
of them.
Salivation.
What is that?
Salivation.
Salivation, lacrimation, defecation, urination.
Gastric emesis.
Why RBS is high?
Bradycardia. Sir?
Why RBS is high?
RBS.
A bit high, na?
Yes, sir.
Stress.
तो बोलो, please speak out. So next lecture.
Past history, the patient doesn't have any comorbidities. In the ER, when the ABG was taken, the pH was 7.1, PCO2 of 70, PO2 of 82, bicarbonate of 21, lactates of 3.24.
So what is this ABG showing?
Respiratory acidosis.
Only respiratory? Pure respiratory acidosis?
For 70.
What do you expect to happen to the bicarbonate when the respiratory acidosis?
If it is an acute condition, for 10 mm Hg rise, one bicarb should be shifted.
Up or down?
Increase it, sir.
Increase.
So it has come
Down.
Sir.
So what it is? Is pure respiratory acidosis or?
Pure respiratory
With the
metabolic acidosis.
It's a respiratory acidosis with metabolic acidosis, no?
Yes, sir.
You expect the bicarbonate to go up, but it hasn't gone up. In fact, it has gone down.
It down, sir.
So it is a respiratory acidosis with a metabolic acidosis.
What is the lactate unit? That's not written. 3.2 is high. In some
Yes, sir. High.
3.24. High. So it is metabolic acidosis. What sir is saying is right. Why there is a metabolic acidosis? Added. Lactate is high. Bicarb is low. What may be the cause of metabolic acidosis in this treatment?
Because of volume loss, because of any
volume loss. Yes, very good, agreed. And
because of
maybe some effect on heart.
Because of toxin related any anaerobic metabolism, sir. The pyruvate is converted into lactates.
Okay.
What is the cause of acute respiratory acidosis in a young person with a normal auscultation? No asthma, no COPD. In a 35-year-old man, acute respiratory acidosis. What are the causes? Normal lung. Night he was fine. Next morning he comes unconscious. ABG showing acute respiratory acidosis. So one of course is poisoning. You said one is organophosphorus. What are the other causes? A farmer comes home in the morning with his acute respiratory acidosis. What are you worried about? Not in the city, I'm talking about farmer. Sleeping in the night and morning he comes with all this.
With tachycardia. Speak out.
So acute respiratory acidosis, the lung is normal. You think about neuromuscular or you think something else, right? Outside the lung. So what are all the causes of sudden neuromuscular weakness?
Chart they are actively answering, sir, actually.
Chats they are answering.
Chat
Someone
they're
says
answering. So which
snake
snake
bite,
bite? Which
stroke,
snake bite common in
GBS.
India? Which snake bite causes this neuromuscular poisoning? Common.
Cobra.
Cobra is not the
Crate and
common.
cobra.
Crate and
Which is the common? Cobra or crate?
Crate, sir.
crate, sir.
Crate. Okay, crate. Anything else can cause acute respiratory acidosis in a young man? History of diarrhea 2 weeks ago.
Bottle.
Pardon?
GB syndrome, sir.
Sir, in chat they are writing GBS.
GBS, Guillain-Barré syndrome. It's also differential diagnosis of organophosphorus. Okay. Guillain-Barré syndrome, organophosphorus poisoning, myasthenic crisis. Botulism is very rare.
Botulism.
Narcotic poisoning also can cause acute respiratory acidosis. I'm just saying that when you have this kind of ABG, you have to be prepared for questions about acute respiratory acidosis. They will only, just because the case is organophosphorus doesn't mean examiner is going to ask you only about organophosphorus. They can go to whatever they want. If they're bored, they'll ask you anything. So I'm just saying, you've got to be prepared for questions related to just the ABG. So you have to know all the causes of acute respiratory acidosis. Of course, COPD, asthma, all that is different, but I'm just talking about other than the lung. So, polymyositis, all that is a myasthenic crisis. Polymyositis is less likely, but Guillain-Barré definitely, snake bite definitely, organophosphorus definitely. Those are some of the things we need to talk about. Fine, go ahead. Hypokalemic. So people are talking, it's hypokalemic periodic paralysis. So all the neuromuscular problems. Okay. Fine. Fine, go ahead.
Patient was given injection atropine 2 mg followed by until atropinization was achieved. Atropinization was achieved at 100 mg dose, and so we started an infusion of 10 ml per hour. We have resuscitated the patient.
What is the protocol? How do you start? How do you give? What do you actually do? What are your endpoints of atropine?
Initially, we have to start with 1.5 to 3 mg of atropine, sir.
And then?
We have to wait for 5 minutes and we have to check for any atropinization signs like decrease in respiratory secretions and dry.
What are the endpoints of it? That's what I'm saying. What is the endpoints?
Heart rate more than 80 per minute.
80, systolic BP more than 80, and decrease of respiratory secretions, pupils dilated, and dry axillars, sir. Dry screen or dry axillars.
So if the heart rate is more than 80, the BP is 90, chest is clear, but the pupils are pinpoint. What will you do?
Is it atropinized or not?
Atropinized.
Heart rate is 80, BP has come up to 90, chest is clear on auscultation, but pupils are still very pinpoint. What will you do? Continue atropine?
Atropinization.
Pardon?
Yes, sir.
Patient was atropinized, sir.
So pupils are
Soft
soft
and,
indication. Nobody's going to die of pinpoint pupils, no? So yes, they are soft indications. If they have them, fine, but you don't. Your main things what will kill them will be bradycardia, secretions, and hypotension. So mainly those are your primary things. All the rest are okay. But if you don't have them, you don't have to worry too much. Okay, provided your BP, BP, heart rate, and secretions are contact. Okay, that's the primary thing. Don't be obsessed with pinpoint. By and large, of course, like you said, most of the time people also will be dilated. But if you have the rare situation, people are not been dilated, don't worry about pinpoint. People if other three objectives are achieved. So how do you give? So you said you give after 5 minutes. What do you do then? If it's not achieved your targets, then
again we will double the dose, sir.
Yeah, keep doubling the dose till you achieve your target. Then you give how much of the dose as an infusion?
10% of that atropinization.
Total dose given for atropinization.
10 mg per hour.
You want to ask something, Dr.
Maybe pinpoint people due to contamination of the eyes. Maybe they have not decontaminated the eyes. Maybe having local symptoms. So main thing is that you have to take care of bradycardia, take care of secretion, hypotension. You have already said. So fluid, why you will give? Why on how much fluid you will give?
With initial resuscitation 10 to 20 ml per kg, we can give, sir, initial of crystalloids for initial resuscitation, sir.
And check for.
And check
that
for.
I'm interested.
And check for any increase in rise in BP or decrease in tachycardia or any clearance of lactate, sir.
And have you heard the word false protocol in hypotension? Fluid administration limited by lung ultrasound.
B profile.
We have to check for again IVC, sir.
Yes, IVC. Then
Because your heart rate and all may not be very helpful, no, in this.
yes, heart rate and BP may not be corroborating with your fluid
We have to
response.
check for IVC and
B
check
profile.
for any B. We have to do for lung ultrasound. For any B profile is there or not, sir. If
So
no
kindly go
signs
through
of
this false Vexus protocols. You know?
yes,
The examiner will not stick to organophosphorus. He will go here and there, like hypoxia, just like sir has said in ABG. Even he can ask if the pH is okay with this PCO2 and bicarb. Have you checked that? It may be a question. Or what may be the causes of hypoxia in this patient? Then he will go into the hypoxia segment. Next, hypotension is there. So it is very favorite area of examiner's talk, and he will go for asking about what are the types of respiratory failure. Type 2 respiratory failure, you have said. What are the types of respiratory failure? I think you know that. Type 1, type 2, type 3, type 4.
respiratory type 3.
Type 3, type 4.
Yes, sir.
Yes,
These are the areas examiners will go and ask. Next, please.
So how do you confirm OP? You said OP positive will confirm, but are there any tests that can confirm OP when there is when there is a doubt?
They have not reached the right.
Serum
They have already given atropine and I think pralidoxime also they are giving in the last line.
Blood test to confirm OP poisoning?
We can send for the serum cholinesterase levels, sir.
You do serum cholinesterase? So which one do you use?
Which cholinesterase?
RBC cholinesterase,
Oh, that is ideal, but what is available? Serum cholinesterase?
plasma cholinesterase or
pseudocholinesterase.
What is that? Pseudocholinesterase. What is that?
that is synthesized in the liver, sir. It will tell about whether the patient has been taken any organophosphorus poisoning or any
The
carbon.
other drug, which other poison does it come down? One is organophosphorus, other one? Which other poison?
Or other problem?
Carbamate, so it will show less, sir.
Which other common poison, common insecticide used in our country is anticholinergic?
Comes with DD with organophosphorus poisoning.
Spray, for cockroaches and all that, very common. I don't know.
Begon spray, aromats.
What does it contain? Carbamates, no? Baygon
Carbamates, yes.
So carbamate poisoning and organophosphorus poisoning, both the pseudocholinesterase levels will be increased or decreased?
Decreased, sir.
So do they prognostic can help you prognosticate severity of the poisoning?
No, sir. RBC cholinesterase only will
Why
tell about
pseudocholinesterase does not help you prognosticate?
because it is synthesized in the liver, sir. Whereas RBC cholinesterase we are directly measuring from the.
So how does it matter?
Why are you doing?
It will tell about the acetylcholinesterase levels, sir.
No, organophosphorus compounds inhibit pseudocholinesterase much more than they inhibit RBC cholinesterase. So, therefore, though if the pseudocholinesterase levels are low, it confirms that this is likely to be either a carbamate or a
OP poisoning.
compound poisoning, but doesn't really anything with severity because it will overestimate the severity because they are much more active against pseudocholinesterase versus your okay. So ideally, what you should do is RBC cholinesterase, which is more accurate for severity, but not easily available, more difficult to perform. Is there any other value of doing cholinesterase levels other than diagnosis? Any value repeating the test?
OP poisoning also can be.
No, any value repeating the test?
What sir is asking, say it is now 100. After 3 days, it is 2000.
Yes,
what is that value?
That OP compound has been eliminated from the body, sir.
So once it starts rising, it rises about 7% only after the OP compound has been eliminated. So it might decided that you don't need any more of a PAM or whatever else. So you can be sort of satisfied that the compound is eliminated. So that's one. The rise in the levels may tell you that though it has no correlation with severity, rise in levels may help you tell you that the compound is now eliminated from the body. But now, of course, the most important controversy. You want to talk about oximes, Dr. Ghatak? Or you want to talk?
Yes, last line. Please read and please defend yourself.
As OP poisoning was confirmed, we started a patient on oximes, pralidoxime, 1 gram IV bolus, followed by infusion of 500 mg per hour.
So how OP poison was confirmed was discussed to some extent. Now pralidoxime. What is the dose? What is the why you are giving?
We are giving to phosphor because the phosphorylated bond has been present between the OP compound and acetylcholinesterase, sir. In order to break that covalent bond between the OP compound and enzyme, we will give pralidoxime, sir.
To reactivate the
acetylcholinesterase, sir.
It's a cholinesterase reactivator.
Yes, sir.
Reactivator.
What are the
What is the
controversies
dose?
about oximes, you know?
Yeah.
Sir,
What are the controversies?
Going to give which organophosphorus
Any papers
compound?
anywhere about oximes? Any papers about the oximes?
yes, sir. In case of
The
Baramati,
famous papers, yeah, Baramati, okay.
Baramati study.
What did that paper show?
it shows that they have given 2 gram IV bolus, sir, followed by in study group and control group they have given 1 gram of infusion every hourly until 48 hours, where the atropine dose has been required, where decreased. Whereas in case of control group, they have given 1 gram infusion every 4th hourly, sir. So they have showed benefit in the decrease in the mortality and morbidity, ICU free days, ventilator free days in case of continuous infusion groups, sir.
What is the amount of atropine?
Atropine requirement
What is
also.
the limitation of this study? You know,
Sir,
what are the limitation? Not
What are the
limitation
limitation?
of this study. Can you generalize the study to everybody?
No, sir. It's mostly done in moderate.
Obviously, all the severely ill patients are shifted to the government hospital. So
sir,
only the moderately ill patients. And one more thing is, they came within 2 hours.
2 hours.
They came very quickly and they were moderately ill.
Most.
So that was a limitation. Which other famous studies you know about oximes?
Vellore study one.
Vellore showed.
Sri Lankan study one done, sir.
What is Sri Lankan study? You know, when did they do it? Was there a control group in Sri Lankan study? No, Sri Lankan study, they did it when there was no PAM available. So there was no control group, but they compared the time when PAM was not available in Sri Lanka versus the time when it was available. So that was like a retrospective control. And of course, Vellore study showed. So why do you think that different studies are different results with PAM? What are the things that affect response to PAM? That's the main thing. What are the factors affecting your response to the oximes?
Aging, sir. Aging is the
What is
most
aging?
important factor, and if the OP compound is phosphorylated, it forms phosphorylated bond with the cholinesterase, acetylcholinesterase, sir. It will de-escalate into permanent. It will de-escalate the and loss of non-enzymatic loss of acetyl group will be there in the bond, sir. It leads to permanent irreversible
Inhibition.
Binding.
Sorry.
Competitive binding.
Which age faster? Which drugs age faster?
Dimethyl.
Dimethyl is age faster, sir. The half-life is around 3 hours.
3 hours.
Okay. So
Theoretically,
Sir,
for dimethyl, you have to give much faster. For dimethyl comes later, it may not be useful. Diethyl, you can continue maybe for even after 24 hours.
24.
Any other, like we said last time, any other kinds of drugs where it might not be useful very quickly, but might be useful a little later. So
profenifos, it is not, oximes are not useful, sir, because their aging is less than 1 hour. If at all the patient arrives to us late in such a group, if at all we give oxime also, it is not helpful.
So one is you said one is about dimethyl versus diethyl. Second is thiones and oxones. What is thiones and oxones? What's the difference? Thiones are prodrugs. They need to be converted to oxones. So their effect may happen after some time. Oxones already there. So oxones onset of action is very quickly. So again, for thiones, maybe you can give it a little later. So if the thione, if it is a methyl diethyl, you can maybe give it a little later. Okay. So these are some of the things. Then like you said, fat soluble versus water soluble. So it all depends upon. So it's not a uniform response to oxime. It depends upon whether it's dimethyl or diethyl, whether it is an oxone or a thione. Okay, where it's fat soluble or water soluble. There's lots of things that can. That is why there's a controversy about PAM. It's not a
you have to use judicially and as early as possible if you are suspicion.
Especially if it's dimethyl, you have to give it as early as possible. Probably come after that. Maybe you should not even give because theoretically, like the Vellore study show, there might be actually be a side effect also. So you have to decide. We individualize the patient, when he has come, what drug he has taken, all that will decide upon whether it is. Though the WHO gives everybody, I agree, but sometimes maybe you should individualize depending upon the nature of the poison and what time the patient has come to you. Okay. Fine. Anything else you
One
want?
more thing, sir, with ABG, there are some solvent, usually how they take this organophosphate compounds. Usually with some solvent, na, with alcohol or something.
Alcohol, sir.
Alcohol.
Most of the people.
These can cause metabolic acidosis.
Yes.
But there may be hypertension related AKI also. There may be this may be the other causes. So should we go to next or
Fine. Okay. Next slide.
Chest X-ray was done, 2D echo was done, which was suggestive of fair LV functioning. Patient was shifted to medical ICU with atropine infusion of 10 ml per hour with a heart rate of 110 per minute, blood pressure of 110 over 60 mmHg with pupils of pinpoint. In medical ICU, patient connected with mechanical ventilation with FiO2 of 40%, PEEP of 6, volume control mode with saturations of 96.
have intubated the patient in ICU or ED?
ER, sir.
What are the precautions during intubation?
Wearing a glove.
Wearing a
double
gloves,
gloves.
double gloves.
That protective
Protective
equipment. Okay.
PPE.
Next, for the patient, what may be the?
It-
Is it a how is the airway? Difficult or easy?
Easy only. No airway edema was there, sir.
He's having all the secretions.
Secretions were
Their
present.
airway is not protected well. You have already gastric lavage has been done. Everywhere there is secretion, or maybe a difficult one. Is full of secretion. What
Secretions, sir.
what about the drug? And he's maybe potentially full stomach. He's having all the gastric lavage.
Rapid sequence was done with rocuronium, sir.
Why rocuronium?
Because succinylcholine, if at all we have given, it will cause phase 1 blockade, sir. Prolonged. It is already the acetylcholine which is available. It is structurally similar to the succinylcholine, sir. 2 molecules have been combined. So succinylcholine, if at all we have given, it will cause prolonged further depolarization of the neuromuscular junction, sir.
What about rocuronium? What may be the dose?
1
for RSI?
For 1 mg per kg, sir.
Nowadays, is it called RSI or something more?
Modified.
Is to be
Modified.
DAI, what is it?
DAI is now called DAI, not RSI.
What is DAI?
The examiner will ask 7 P's for RSI. Whenever you utter this word RSI or DAI, examiner question is what are the 7 P's? You have to read and you have to immediately speak out. His preparation and everything. So rocuronium dose, you are not confident with 1 mg per kg, or you will for RSI or DAI, will you consider more?
1.2.
So what about the mechanical ventilation?
Sir?
How you are ventilating the patient?
In volume control mode, sir. With FiO2 of 40 and PEEP of 6.
So before that, let us remember, please, like he said about DAI and all the 7 Ps, etc. You need to know, because not just for organophosphorus, head injury, so many things, spinal injuries, everywhere they'll ask you about that. So please know that, because that's going to be important. We won't go into that much. We won't waste your time now, but all of you all need to know all that very well. That's very, very important. If you don't know that, you're going to fail straight. There's no question. So
What is delayed sequence intubation? What is, you are saying RSI, rapid sequence intubation. So there must be delayed sequence intubation also.
Okay, sir.
Please read that. Okay. Sir, mechanical ventilation.
You were talking about ventilation, you wanted to ask them something? Or
No. What is lung protective ventilation strategy? You should know. You know? PEEP 6. What is the PS or PC? They have not mentioned. And what about it is full of secretion? How often you will do suctioning? You have intubated the patient because A is not good, B is not good, C is also falling. You will immediately intubate, then go gastric lavage, and it is full of secretion. Atropinization, it will take time. So what is the suction pressure? What will be the suction rate? So you have to read that also. Okay.
the other question they sometimes ask is that he's got a lot of secretions, but his tachycardia, he's got tachycardia, he's becoming abnormal, his behavior is abnormal. What can you do in that situation?
Tachycardia is not a contraindication.
And he's becoming a little more violent. Tachycardia is okay, but he's got secretions, but he's becoming violent. So what can you do? Some people say you could switch to glycopyrrolate, okay? If the CNS toxicity is beginning to set in, and you still haven't achieved your this about secretions, maybe you can use glycopyrrolate rather than, because glycopyrrolate does not cross the blood brain as much as atropine, so maybe. Also,
Sarah was hinting, yes. What Sarah was hinting, Sarah was basically asking when to use glycopyrrolate in place of atropine. And what are the atropine toxicity symptoms?
Confusion,
agitations,
increased fever spikes.
how do you treat the agitation? Can you restrain them? Can you tie them up to the bed?
Yes. But they are violent.
What is the danger of restraining in organophosphorus poisoning? No, they say they're already on atropine. If you restrain them and they're already agitated, they keep moving, they can develop hypothermia. So better to use sedative, diazepam. Don't just set them up, okay? Because you can get hypothermia. Because these people are doing a lot of muscular activity, plus they're giving the atropine, which itself causes the danger of hypothermia. They can develop severe hypothermia. So you don't, of course, it's still common in our hospital to tie up people, but don't do that. You just sedate them, okay?
Okay.
No physical restraints. You have to sedate them. Of course, in that situation also, you might consider using glycopyrrolate if your secretions, etc., are still there. The other question they sometimes ask is that there is bradycardia not responding and he's already developing neurotoxicity. So Dr. Peter and all from Vellore, they use adrenaline in that situation because it may be because sympathetic, this is blocked because it's cholinergic. So they use adrenaline. The main problem now is bradycardia and hypotension, but secretion is not a big issue and there is already signs of neurotoxicity of atropine. They have used adrenaline. So they might ask you that question also. What do you do when the bradycardia and hypotension don't respond to atropine? So you can consider using, it's from Vellore, Dr. Peter has that paper where they use adrenaline.
So in pharmacology, there is excellent mnemonic as hot as hen. What are those? Examiner will ask these things for atropine poisoning. Toxicity. Okay. As mad as hatters, as dry as bone. You have to remember those. It is easy.
Go ahead.
Go ahead.
The repeated ABG in the medical ICU was pH 7.3, PCO2 of 36, PO2 of 143, and bicarbonate of 18, lactates of 1.7, sir. Sodium of 141, potassium of 2.8, and chlorides of 104.
So what are called acidosis with hypokalemia? What does acidosis normally do to potassium? What does acidosis normally do to potassium?
Shift, sir.
Shift where, out or in?
What's it?
H plus
What's it?
ions will move in.
So hyperkalemia.
Potassium will come out, sir.
So what are the causes of
Acidosis is
hypokalemia? Hypokalemia with acidosis. What are the causes?
RTA, sir.
Okay, RTA. What else? This patient doesn't have RTA, I suppose. What else can cause hypokalemia and acidosis?
Sepsis, sir.
Sepsis? Hypokalemia? Why should sepsis cause hypokalemia? So what is catabolism?
Okay.
with kidney injury, maybe.
Hypokalemia. AKI, somebody mentioned, they will cause hyper, no? I'm talking about hypokalemia. You said RTA number, but that's commoner than that. What is the commoner cause of that? Not diarrhea can cause, okay? Diarrhea can cause acidosis.
Hypokalemia.
Any drugs can cause hypokalemia and acidosis? If you go to
Commonly used in ICU. Often we are using during extubation, maybe to get advantage of that drug.
Lasix, somebody, Lasix was metabolic alkalosis and
Metabolic
hypokalemia.
alkalosis.
So Lasix is
Carbonic anhydrase inhibitor,
acetazolamide.
diamoxacetazolamide.
And sometimes amphotericin also. Of course, nobody uses lipo conventional
Yes.
nowadays, but most important is acetazolamide. Okay, it's used either for high altitude mountain or glaucoma and all that. Okay, acetazolamide. So all the other diuretics cause alkalosis and hypokalemia, but acetazolamide causes acidosis and hypokalemia. Fine, go ahead. Next slide.
These were the investigations, sir, on 26th. HB of 15.7, total leukocyte count of 22,160, and platelet count of 2,01,000.
So would you start an antibiotic?
No, sir.
Why?
Reactionary.
Maybe aspiration. Which antibiotic you will prefer in aspiration?
Gram negative coverage, sir. We will give either basic plain monoseph or usually we will give clindamycin, sir. Anaerobic cover, sir.
It's a little controversial about aspiration and all that because now people say the role of aspiration, anaerobes in aspiration is debatable. So, I mean, I'm just saying that sometimes, of course, leukocytosis, there are lots of reasons. So you don't straight away jump to antibiotics. You might consider, as like you said, aspiration definitely is one possibility. So if you've got fever, purulent sputum, patches on the X-ray, difficult to separate from secretions, you might consider. The question is, you can consider, see if it's 1 day of intubation, it can still be community-acquired organism. So even your augmented might be good enough. Because you can't give only, I mean, you can give Clinda also, but or augmented can be good enough. But question is, of course, whether you need to give antibiotics at all, again, is debatable. You'll probably follow up the patient and see how things go.
Yes.
Fine, next slide.
Next slide.
Blood urea and serum creatine was 27 and 0.8. Sodium, potassium chloride were.
Fine, next slide.
Cholesterol we have repeated or only one
Only
value?
1 day we have sent, sir.
Okay.
Day 2, patient continued on atropine at the rate of 8 ml per hour. Heart rate was 103 per minute. Pupils were 2 mm reacting to light, and atropine and PAM infusion was around 25 ml per hour. On auscultation, bilateral air entry was present and minimal basal crypts were present, sir. Patient was started with RT feeds at 30 ml per hour and thromboprophylaxis was started and ABJ was done, which was suggestive of pH 7.35, PCO2 of 40, PO2 of 147 and bicarbonate of 26, lactates of 1.01. On mechanical ventilator of FiO2 0.3 and PEEP of 6, sir.
Fine.
Okay. Good oxygenation.
Day 3, atropine was tapered to 5 ml per hour with a heart rate of 115 per minute with a blood pressure of 130 over 80 mmHg, pupils 2 mm reacting to light. Patient had fasciculations and tremors. So PAM infusion was continued for another day. Patient tolerated the RT feed, so we have increased the feeds to 60 ml per hour.
If it was not tolerating, what is the likely cause?
Then
If you had high gastric rates now, what is the likely cause?
Paralytic ileus, sir, because of opioids we are
because of atropine.
One is opioids. You're right. One is opioids. Which other drug?
And you have already mentioned one thing.
Atropine.
Atropine also is anticholinergic. So atropine and opioids both. And
Atropine, okay. Okay. Both. well taken. And
Opioids, sir, because we are sedating him with the fentanyl.
you just said, na, potassium is not appropriate, na? Maybe hypokalemic.
So potassium, atropine, and your fentanyl. Okay. And probably you can come down the atropine because heart rate is 115. You don't need such a high heart rate. You don't need such a good BP.
Hmm.
So just because, like I said, just because the pupils were 2 millimeter, there's no point. Like he said, it could be even local. This of the drug, no? So you can probably reduce the atropine, no, in this situation, because fasciculation tremors can also happen with atropine. I'm just saying it could be.
Toxicity.
Hmm. Yes. You're getting good PF. Next day, what happened?
We further decreased the atropine dose to 2 ml per hour, sir. Pupils were 3 mm with a BP of 130/60, heart rate of 110 per minute. Occasionally, patient had fever spikes, sir. 101 to 102 degree Fahrenheit. We thought of atropine-induced fever spikes, sir. PAM infusion was stopped on day 4. And we continued mechanical ventilation, sir. On day 5, we extubated the patient, sir. He was tolerate, atropine was tapered, and
Yeah,
patient
but
was
suppose you were
tolerated.
trying to, suppose before you extubate the patient, what else you try?
Yes.
Next slide.
And what will you look?
We
Check.
will see for the we will keep the patient on spontaneous breathing trials, sir. We will check for PF ratios. We will check for the neck.
All that is fine. So they will extubate him straight away after that?
No, he's saying something.
Neck.
Please speak out.
We can see whether the patient is able to flex the neck.
So suppose he's not able to flex his neck, then what are you worried about?
Then we will worried about intermediate syndrome, sir.
Intermediate syndrome. Okay. What is intermediate syndrome?
Why?
It is occurred because 24 to 48 hours after the acute cholinergic crisis, sir. In this condition, the patient is having proximal muscle weakness, sir, like neck flexors, upper limbs, and also respiratory muscle weakness may be present in these patients, sir. It may be occurred because of
because of
if at all we have not given oximes dose decreased inadequate oxime dose, or because of any
something more.
desensitization of the receptors.
Something more. Property of organophosphorus. Classification you have already. In classification you already discussed. In classification you have already discussed. Which type of organophosphorus will create this menace? This intermediate syndrome.
Fat soluble and dimethyl group.
Yes. Why? Why fat soluble?
Because they slowly released from the tissues, sir.
What is that called?
Redistribution of the.
Yes. Good. Redistribution of the drug from the fat soluble fat site. And why it is called intermediate?
It occurred
something
between the acute cholinergic crisis and
chronic.
And what?
Delayed.
And what?
So what is delayed paralysis?
What? Yes.
Sir?
Yeah, what is delayed paralysis then? What are the features of delayed paralysis?
In delayed paralysis, we will have paresthesia. Initially, the patient will complain of a sensory and motor neuropathy will be there, sir. Initially, the patient will have any burning sensation, paresthesia, numbness, and tingling in the lower limbs, sir.
We're interested in which muscle group? Which muscle group the OPIDP will hit? Opioid-induced delayed paralysis in which muscle group? Why it is called intermediate?
Proximal muscle.
Proximal muscle is called intermediate.
Proximal, no? Intermediate is proximal. Delayed causes which muscle?
Intermediate is proximal. Delayed is distal.
Distal.
Okay.
Distal, no? So intermediate affects, like you said, the muscles of respiration and all that. This delayed. So intermediate syndrome, the generally might require intubation, tracheostomy, etc. Whereas delayed is mainly the distal muscles. Okay. Like you said, no, legs and hands and all the burning and weak. Distal, more distal than proximal. Any other neurological manifestations of organophosphorus? Delayed? Other than the paralysis, any other manifestations?
There may
Neurological
be
manifestation.
food because of the nerve. Even the nerves have been involved,
That
sir.
is neuropathy of weakness. That's okay. Any other central causes? Central,
DOP,
Romb,
have you heard?
sir.
they cannot delete.
DOP,
They can have extrapyramidal symptoms. They can have encephalopathy.
Ah.
How do you treat that? Do you know? Which anticholinergic drug has best penetration in the brain? Which is the least penetration? Which is the best penetration in the brain? Anticholinergic.
Physostigmine and neostigmine.
One.
Neostigmine.
Anticholinergic. I'm
Anticholinergic.
sorry, cholinergic. I'm not saying anticholinergic. You should be giving a cholinergic drug. Not anticholinergic. Neostigmine, you're right. I'm talking about the atropine and all that. Cholinergic drug. Which cholinergic drug has best penetration in the brain?
best one is
Anticholinergic drug. I'm talking about. Not neostigmine. Neostigmine is wrong.
Anticholinesterase.
Which one will you give?
Which cross?
Atropine, which is best penetration? I said glycopyrrolate doesn't have penetration in the brain.
Atropine will penetrate the brain.
So better than atropine, any other drug can penetrate the brain? Better than atropine? For the delayed encephalopathy and extrapyramidal symptoms, which drug would you prefer? They say either scopolamine or trihexyphenidyl, okay, because they have better penetration in the brain, okay? So atropine, of course, has good penetration, but better than them are trihexyphenidyl, scopolamine. So if you want neurological effects, you can give scopolamine or trihexyphenidyl. If you don't want, use glycopyrrolate. Of course, atropine has both. So, but you can come with encephalopathy. You can even mimic brain death. Okay, that's why you can even mimic brain death.
Yes, sir.
So the only thing I think is how do you separate brain? Somebody asked how do you separate brain death from delayed encephalopathy caused by organophosphorus compound? Somebody said we want to donate his organs. So can you donate his organs?
No, sir. In brain death, the pupils will be dilated and fixed.
So pupils are the only thing. Pupils will be still pinpointed. So that's the pupils. Otherwise, don't jump to donating organs. That's the only thing. Of course, that's one important question they'll ask about. Fine. So next slide is.
you have managed well.
We
Now
shifted the
patient can
patient.
be extubated and shifted to HDU. Very good.
Fine. So nothing much. So basically, I'm just saying that in an exam, of course, your focus may not necessarily be organophosphorus. Of course, that is there, but
Yes.
they can ask about several other allied, about intubation, about rapid sequence, like he said. They can talk about acid ABG. So they can ask you anything. Don't get just the organophosphorus case. They're going to ask you only about organophosphorus. You need to know about all the other allied things, other poisonings. So carbamate, organochlor, they may ask you. You know what is organochlor?
No, sir.
The organochlor compounds also are there, which they come basically with seizures. I think there you're probably not supposed to use the conventional anti-epileptic medications. You're supposed to use midazolam. So anyway, so they can ask you when you have organophosphorus, they can ask you about other poisons. They don't have to stick to organophosphorus. So that's one other thing. They can ask you about snake bite again because there's somewhat, there are some differences. So I'm just saying that don't get obsessed with of course, organophosphorus you need to know very well because in India, some poisons you have to know very well. Organophosphorus, snake bite, all these are standard things. You need to know paracetamol. No question. You can't afford to make any mistakes in those things. Okay. Organophosphorus, no question. All the classifications that we talked about, fat soluble, dimethyl, thiones, oxones, WHO classification, all that you need to know pretty well. And the impact on the use of oximes, in which you will use oxime, which you won't use oxime. That's very important because that controversy is still going to be there. So, you need to know where it is most likely to benefit, where it is least likely to benefit. Okay. So all that you need to know.
So in exam also dictum is like that. It is a easy case. So maybe questions may be not from the case, maybe outside the case, or it is a difficult case. So I may be failing, not like that. So examiner will pick the easy areas first so that you can answer well. It will build your confidence and then he'll ask something more difficult. So they're also there to help you. Right?
Yes, sir.
So a myasthenic patient consumes organophosphorus compound. What will happen to him? Patient with myasthenia gets depressed and consumes organophosphorus.
They will have type 2 respiratory failure. ఇంకా పెరుగుతుంది.
Further worsening of
Further
myasthenia.
Pardon?
Going to
Yes.
What is
crisis
the
of
treatment for
myasthenia.
myasthenia?
Myasthenia can be sort of a treatment.
He'll improve, no? You're giving a he'll improve. His symptoms will improve. It's like giving neostigmine, no? It's just a trick question sometimes they ask you. He'll actually get better. So at least, of course, depending how much he has taken, he can go into cholinergic crisis. But otherwise, it is like giving him neostigmine, no? You give him a cholinergic drug, no? So he might improve.
Yes,
Fine.
sir.
We have covered most of it. Any other questions?
Yes, sir. Yes, sir. I think, yeah, I covered
Audience
almost.
has been very good. They
One
also
thing is like any
Yes,
patient
they
who's
presented
coming
well.
with, yeah, the patient, like one thing is like most of the times we do get patients like unknown poisoning compound. By the time patient tells to anyone, he might have been drowsy and nothing much been traced. So generally what we look at is the toxidrome approach. Any light on that, sir? Dr. Tanmay, sir, do you want to put any light on that?
The toxidromes are, you have to know the toxidrome, what are the sympathomimetic, what are the cholinergic, what are the anticholinergic. These are the main toxidromes we are getting, and the mnemonic, as hot as rain, what are the anticholinergic symptom, if it is there, or maybe amphetamine poisoning, patient may be restless like this, or this cholinergic substance poisoning, patient will have increased secretion from everywhere. So these are the important things, but you should always remember the basic ABCD, ABCD, ABCD. And when you are in ER or ICU situation, or in confronting this patient, it is important to know the toxidrome, but as well as you have to medically manage the patient is also important. It's a prime important. So ABCD approach, then you'll check for toxidrome and everything. And another area, it should be um, focused for this medical legal area. You have to go for some I think police reporting also in this patient for suicidal, that we often forget. Last but not the least.
Yes, sir.
I think
And
pupils, pulse, BP, temperature, heart rate, these are things these are important things, and the combination of these things will lead you to
Related to toxidromes.
which particular toxin going to be usually the simple things have the pulse, pupils, BP, heart rate,
Pupils, CNS.
temperature, altered sensorium. These are some of the important, and combination of this can give you different, poisons, suspected poisons, of course. And that's the.
yes, sir. So sometimes we do send like urine toxicology assays and all, which most of the times they give as a qualitative assay rather than quantitative. And the most common thing is they give the benzodiazepines in the ED, and then if it comes positive and they sometimes attribute. I think that should be interpreted with caution.
I agree
I don't think
completely.
so, like correct any proper assays if there is an unknown poison other than like mind the gaps, what we say the ion gap and osmolar gap, those things also has to be stressed upon. Do you have any like comprehensive test methodologies, sir, in India? I don't think so.
I think so. I mean, you have help centers, but I don't think there's any lab which actually does an assay. But your point about osmolar gap is important in patients who you don't know the poison. I agree. You have an unexplained acidosis and an osmolar gap. Do you all know the residents? You all know what an osmolar gap is? What do you mean by osmolar gap? How do you normally determine the osmolarity of the serum?
I was mentioning now, the solvent is important. Say patient has taken it with alcohol. What will be the osmolar gap? What will be the anion gap?
Measured osmolar gap
How do you
minus
calculate osmolar gap?
measured osmolar gap minus serum osmolar gap. Serum osmolarity.
Minus calculated.
Calculated.
Measured minus calculated. Okay.
Yes, sir.
Measured minus calculated. How do you calculate? You know the formula, no?
2 into sodium plus blood urea nitrogen divided by 2.
Sodium plus potassium, some people say, plus blood urea plus what? One more thing, no?
Plus glucose
Glucose upon how much?
divided by 18, sir.
And blood urea divided by
2.4.
2.8. Anyway, so if the measured osmolality is much more than this calculated osmolality, then there is some other osmotically active agent in the blood. So you have to, that's called the osmolar gap. Then you think about things like ethylene glycol poisoning, methanol poisoning. Okay, some other osmotically active agent is there in the blood. That is why your measured osmolality is much more than a calculated osmolality. So you worry about a poisoning caused by, that's what Dr. Kaladar was talking about, that you need to think about important and unknown poisoning. Also, obviously, need to
Another important area is our ECG. Often forget, like blood in this patient also. TCA poisoning say. The ECG will say something. Bradycardia, maybe the DD, different blocks.
important. And bizarre arrhythmias you will see in poisoning. So you always have to do an ECG. When you have got a bizarre rhythm, you always think of like you said, tricyclic anti-poisoning or any other poisoning.
So another thing, sir, most of the times in organophosphorus poisoning, suppose after 5 days and all patient gets better, most of the times we are stuck with how to prognosticate. They ask that, yes, my patient is improved. Do you think is it out of danger? So this is a common scenario practically we come across. So generally, what do you think, sir, Ashit sir, like how to prognosticate, what to keep in mind and all?
Obviously, you have to prognosticate depending on the kind of poison, like you said, it's very difficult because if it's a fat soluble, you might tell them they may develop delayed effects. But otherwise, I think you have to be cautious. Maybe if it's a water soluble, it's a diethyl compound, all that, then maybe you can, the WHO grade, all those things will probably be factored in. There's not one way you can. So, but I would think.
Sorry. There is a scoring system available. I think someone was I am reading somewhere. The dose of atropine, the acetylcholinesterase reversal by 4 days. These are the important things. Intermediate syndrome is there or not? What about the diaphragm contractility? These are neuromuscular weakness persisting or not?
So that's available somewhere. Where is it available, Dr. Ghatak? Is it available somewhere, that scoring?
Sir, I was reading somewhere.
No, if you can give it to these people, it's better for them to know. It's a good point.
Is a scoring system available also?
The link or something for that. It is for all of us. Very important to know that. You have the Dr. You know Dr. Kaladar about that, the scoring system? Where is the article? I don't know. We'll have to read up.
I will try to share, sir. One prognostication scale is there, sir. POP scale it is called.
That's what he talked about.
Organophosphorus scale, where there is different parameters depending upon that they categorize as mild, moderate, and severe poisonings.
Then you can confirm.
But most of them are included like with whatever we discussed, like pupil size, respiratory rate, heart rate, fasciculations, level of consciousness, seizures, and these things have been included in that. It has been actually from India only, I think. Exactly, I don't know from where, but our people only proposed it, I think, way back 2008. So one more last question, sir. Regarding nowadays, more and more people are concentrating on extracorporeal therapies. So I don't think so. In organophosphorus, not much of use.
I don't think
some papers I think are there here and there, but I don't think so much are
really. Even plasma people have tried other things, but
magnesium
is highly protein bound and all that. I don't think any reason otherwise.
Not much of. But wherever applicable, probably I think as a toxidrome approach, if it is possible, do it early and so that the outcomes are better, I think. Yes, sir. I think. Any final comments, sir? Ashit, sir?
No, I already told them what what to expect.
Exam point of view, tips for students, sir. I think we discussed 1 or 2 tips from you, like from this presentation.
Like we say that organophosphorus is a simple case, so you can't afford to go wrong. In fact, sometimes when you get the simple case, it's more dangerous because people don't tolerate mistakes. If you get a more complicated case, they will forgive. So some of these things you can't. Tropical illnesses, poisoning, snake bite, you can't afford to go wrong in India. So you have to, these are things that you can't afford to go wrong. So some of these things you need to. And like I told you, other thing, of course, when you're preparing mentally about the case, don't be prepared for questions tangential from the poisoning. There may not always be only poisoning. They may ask you, like I said, about anything, ARDS management or acidosis. Like we asked you about acidosis and hyperkalemia, all that. So you need to be little, when you're preparing, when in 10 minutes you have before the case, go through everything that you're talking and just think mentally what questions can be asked. Like when I say ABG so and so, what question can be asked? Each thing you utter, ask yourself mentally, what question can the examiner ask me, so that you're sort of, see, when they ask you questions, you're at spinal level, you can't answer. So before that, each statement you plan to make, you have to ask yourself what potential questions they can ask me about this, anything, you know, what is the occupation or whatever they may ask. So you need to just saying that mentally prepare yourself for all sorts of questions. Or better, the only way you can do all that is to keep presenting to each other. There's no other option. To keep presenting before the exam. At the exam, you're at spinal level, you're not going to be able to, you know, think rapidly that time. So unless you've answered that question before, unless you've been asked that question before, very difficult for you at that moment to answer. So I think the only way is to talk about hypothetical cases or whatever, and just keep asking questions, firing all sorts of absurd questions, whatever you want. Just keep asking questions, because you don't know how rational or irrational your examiner is going to be. So you have to be prepared for all kinds of questions. That's all.
Dr. Tanmay sir, final comment.
My 2 cents is identify your strong areas, and all, as Sir has said, you have to guide, you have to think what question they will ask, you have to guide those areas, preferably to at least score good marks. And I am sure you'll do better.
He's saying you have to lead the examiner to your.
Yeah, yes. You have
It's
to
a game
lead
of
to
chess.
some
You have to
extent.
make them move to your
Like,
strong area.
yes, for this thing, you have to read AVG, just everything well, every basic thing well. Examiner will not entertain mistakes in those areas. If you mistake in shock, if you mistake in ARDS, if you mistake in hypoxia, they will not tolerate.
Yes, sir. Yes, sir. So the bottom line is, I think, as Ashit sir and Tanmay sir told, I think keep presenting, be proactive, and keep presenting more and
Yes.
more cases. Expose yourself to that, so that the expression becomes more confident in exam. That is very, very important. I think, thank you very much, sir. I think we had a very good session. I think more than 120 people logged in with very active discussion from their side recently. I think Dr. Ashit sir and Dr. Tanmay sir, thank you very much for providing your very good clinical insights, very helpful. And Dr. Vaishnavi and Dr. Vinay for bringing out that case for a very good discussion. And I thank Yashoda Hospitals, our digital and branding team, for providing this platform regularly. Thank you very much, sir. Good night. Thank you.
Good night. Thank you, Tanmay. Thank you. Good night.
Thank you, Kalada sir. Thank you, Ashish sir. Thank you, Kola sir.
Thank you.
Thank you, Vaishnavi and Vinay. Very well presented.
Yeah, you presented well, don't worry. So we have to ask you today. You have to prepare you for the worst. Thank you.
Keep on improving. Thank you. Thank you.
Thank you. Thank you.
Thank you.